Welcome, welcome to today's event. Thank you for joining our seminar today, Unlocking Insights, the Emotional Dimensions of Urinary Incontinence. Today, joining us will be Dr. Michael Cohn and Julie Blacker. I'll give you a short introduction to each of them now. Dr. Michael Cohn is an experienced chairman and CEO, founder of multiple successful international businesses. In his career and as an MD, he's combined his seasoned leadership with visionary and entrepreneurial mindsets in industry and philanthropy. He was trained and certified as a medical doctor in Stockholm. After a few years of clinical activity, he took leadership of the family's innovative and high-tech distribution business, which he exited in 2014. For more than 10 years, Dr. Michael Cohn has been innovating male and female medical products. As CEO and co-founder of TillaCare, he leads an international team who addresses a significant unmet need for many women and their families globally who are suffering with urinary incontinence. On a personal level, Dr. Michael Cohn loves designing, marketing, and education and sales, combining his many years of experience, and at that same time, learning something new every day is rewarding. Our other guest speaker today is Julie Blacker, CEO of Pelvic Tech. Julie is a pelvic floor expert, occupational therapist, and passionate women's health and pelvic floor advocate. She's an expert creator, problem solver, healer, lifelong learner, researcher, and innovator. Julie is the founder and CEO of Pelvic Tech, a company that has revolutionized the pelvic device distribution industry. Pelvic Tech clinicians feel strongly about making sure that their clients can get the best and most appropriate devices with a clear and thorough knowledge of how to use them. By helping people to take control of their own health and recovery, they can work much better and harder to heal and restore their own pelvic floor functioning. Julie is responsible for developing in-services, training, presenting, marketing to medical teams, clinicians, consumers, and creating resources, selling the therapeutic devices that their clients need. So again, thank you both for joining us today at this wonderful event, Unlocking Insights, the Emotional Dimensions of Urinary Incontinence. We welcome you. So our first today will be our first questions today will go to Dr. Michael Cohn. Welcome, Michael. How are you today?
Thank you. I'm very well today. I'm looking forward to this. Thank you for introducing me and welcome to the webinar.
Thank you. All right.
Looking forward to
Michael,
this. Looking forward. Yes.
Thank you. So our first section today is going to be for both Michael and for Julie to discuss different aspects of understanding urinary incontinence. And first, Michael, we're going to have you go through for us a brief overview of urinary incontinence and its complications.
Okay. In order to understand the complications, I have to, in a simplistic way, try to describe for you how this controlled mechanism of voiding or excreting the toxic substance urine from the body is happening. And then from that, we can go on to see what is going wrong and what are the consequences. So I'll try to keep it as simple as possible. But as I said, the kidneys excrete continuously the urine into the bladder. And the bladder is actually a muscle, and it's also controlled by the autonomous system, something we can't control ourselves. When the bladder is gradually filling up with urine, it stretches a little, and in the brainstem, we call it the pons area, it starts to register that we soon need to void, that we need to get rid of it. It's going to fill up. And while the bladder stretches more, the nerve sends out more signals that now may cause contractions of the bladder, and we really feel an urge to soon void. This all happens involuntarily. It's called the autonomous nerve systems. However, the urethra connecting the bladder to the outer world, where the urine has to pass, is surrounded by a pelvic muscle, or we call it a sphincter, and that is in a default mode is closed and it holds back the urine. So when we come to the bathroom and want to void, the sphincter muscle voluntarily relaxes, allowing the voiding of urine. So here we have a delicate balance of involuntarily contractions and sensations and a muscle sphincter to resist that pressure caused by the contractions. That is a very simple way of explaining it. As you may understand, many things can go wrong in this system, and they do for many of us, for many different reasons, and we'll go through some of them here in the seminar. Um, but it can be due to normal life cycle events like age, menopause, giving vaginal birth, or due to lifestyle and some diseases. So we'll go through some of them here to see what can be. So with the age, the wall of the bladder gets a little stiffer, and we may feel that urge sooner and stronger than when we were younger and had better elasticity, especially when the beard goes gray like this. Is something happens to both men and female. These sudden contractions that sometimes causes leaks are called urge, and quite normally also with age you sometimes call them threshold incontinence. You need to go to the bathroom, you feel that quick urge. But it can also be exacerbated by diabetes or neurological diseases like MS, and in men it can appear due to an enlarged prostate. Um, with age, we also produce more urine at night, and we have to get up more often to avoid. And that's why nighttime incontinence or nocturia and eresis, when we leak at night, is a common problem, uh, also at an older age. And there are some side effects that we have to go up very quickly at night, and we lose our blood pressure, or the blood pressure drops, and we can fall, and it can lead to hospitalization. Another way, if you have, so these are the urges and happening automatic, but there can also be a problem with the sphincter. Let's say you're coughing or you're training and you're increasing the abdominal pressure, you're putting external pressure onto the bladder, and and you can cause a leakage. The sphincter can actually not hold against that pressure. It can be an external pressure. It can also be the contraction of the bladder. But in the case of abdominal pressure, and you have incontinence from that, we call that stress incontinence. Can also happen in obesity when the tonus and the tone of the muscle changes, or very sometimes with post-vaginal birth, where you didn't rehabilitate after giving birth, and you need to activate the muscles and train them afterwards. And then you can, at quite an early age, get stress incontinence symptoms. And the pelvic wall then is weakened and damaged, and I think Julie can speak more about that. Neurological damage due to MS, stroke, and dementia also affects the central nervous system and its pathways, controlling, voiding both the voluntarily and involuntarily, as I explained. And in serious neurological disorders, where spinal lesion or MS, the muscle sphincter cannot relax, and then you actually have urine retention. You cannot void at all, and after some time, the bladder gets really very extended, and you get overflow incontinence, you call it. So in order to manage that, you actually need to put a catheter in and empty the bladder mechanically in order to control that, or have it at an indwelling catheter. If you combine, and in order to manage that, you might want to combine a catheter and an external device at night to control the nighttime leakage. A combination of these conditions, the neurological, where you basically have contractions and you cannot hold the urine at all because of sphincter dysfunction, is called mixed urine incontinence. And that leads to constant leakage, and usually it's worse at nighttime, and needs management in order to manage that with different ways of collecting urine. We can also see that after radical prostate operation, prostatectomies, due often to prostate cancer, they can have similar symptoms. So this was a very overview on like the mechanisms of the neurological and mechanical sphincter functions. On the side effects, that's part of the question, I understand, Christy. From urinary incontinence, we have to understand that, first of all, urine is a toxic substance. We don't want it on the skin. We have to get it away from the body. And that's due to the high pH, which is, urine is a basic system, and our skin actually likes slightly acidic environment. So the urine ruins the skin barrier, and it causes inflammation, redness, and ultimately wounds if it's not cared for after prolonged contact with the skin. We also see, as a side effect of urine incontinence, often urinary tract infections. It's also often associated with incontinence, and can also be due to hormonal factors, a vulnerable urethra that doesn't close properly, and also the treatment with adult diaper, which you can have contamination inside an E. coli, and that might make you're more vulnerable for urinary tract infection. So you can actually attribute some of the side effects not to the actual incontinence, but to the treatment. So we can separate that also. But there are other side effects which are basically social and psychological, because there's a lot of stigma being incontinent, and that changes our behavior, and that can cause other side effects. So the fear of smell and the embarrassment of wetting yourself, maybe the sexual function will be impaired. You don't feel that closeness, and you have a hard time relating to your partner because of your fear of incontinence, and that can lead to depressions. Very common, isolation, depression, and another side effect, on your caretaker, your partner, have maybe to take care of you and help you, or your children. And these are also kind of other side effects you can have from incontinence. And another strategy because of urine incontinence is that you decrease the intake of fluid because you don't want to load the bladder, and can lead to dehydration and a lower blood pressure, and you might fall. You go up in the night, you fall, and you can break a bone, and you get into the hospital. And these strategies, which we have to sort of isolate ourselves and decrease intake of fluid, actually worsens the prognosis. So this is very important that we understand why we have it, how we can deal with it. Is there an underlying cause that we need to deal with that? So that's very, very important. Yeah, I think that's a quick one.
Thank you so much for that overview of urinary incontinence, its complications, its valuable insights on a complicated problem. Next question for you, Michael. How significant actually is the problem of urinary incontinence on public health? And are there any demographic groups that are particularly more affected that you'd like to discuss?
Thank you, Chrissy. Yeah, this is very interesting. I mean, this is something we don't talk a lot about, but a common number is that about 5 or 10% of the population globally, we don't know because people don't speak about it, and the numbers come out a little differently depending who you talk to, are believed to suffer from incontinence. I've seen numbers between 2 and 300 million people globally. That's more than US population total suffering from incontinence. And at younger age, it's about up to 6 times more common in women. At an older age, it becomes a little more equal, but it's very commonly women that are encountered in the healthcare system with incontinence. Later with men, it's more due to the prostate. So in the US, about 32% of all women report symptoms monthly. That's 1/3. And 22%, about 28 million women report more severe incontinence. So basically, it's all around us. It's all over the place, and we really don't talk about it, considering that about a quarter of the of the population really suffers from it. And there's a cost to it. It affects you in other ways. On the personal level, we talk about $20 billion costing for pads, operations, insurance fees, and so on. This is in the US only, and we're talking Europe, it's the same number, and Asia and South America. So globally, this is a huge problem. And costing for the society, we're talking about longer stays in the hospital because of incontinence, infections, caretakers having maybe to stay out of work to take care of your mother, take care of your father, and so on and so forth. You talk 10 times $200 billion cost. And there's also cost. So, I mean, looking for insurance policies to cover solutions with Medicare Part B becomes very important for the individual. And if we talk about risk factors here, so age we spoke a little about, but it's not all. Obesity, a BMI over 25 is another risk factor. Of course, prior vaginal birth, we spoke about that if you don't rehabilitate properly with training. Anxiety can be caused by depression, but it can sometimes also be a reason for depression. Um, um, of course, you have other things like diabetes or neurological MS and other neurological diseases that can affect this, of course. But interesting, we see that non-Hispanic whites have a higher incidence and prevalence of incontinence than if reported from Black, Asians, or Hispanics. We can discuss later why that is, why we think that is. There is no really clear answer. And of course, you have an age related here. From age 70, you have about almost like 50% or more. So it is everywhere, and it should be examined why and noted and considered in any care situation. Definitely. Thank you.
Thank you so much. That's a great overview, and you really highlighted with some astounding numbers the significance and the impact of urinary incontinence on public health. Plus, you gave us a great segue to introduce Julie. Julie, thank you so much for joining us today. Welcome.
Hi, thanks so much for having me.
Absolutely. So we built that foundational physiologic understanding of urinary incontinence. We're going to build on that psychological impact. Can you tell us, how does urinary incontinence affect a woman's emotional and psychological well-being?
Yeah, so it is a huge problem. As women, we are taught to look beautiful and be this whole person and be what everybody else wants. And then here we are. If we are affected by urinary incontinence, there is the shame, the embarrassment, the social stigma of it. Um, it creates so much psychological distress as women are feeling judged and ridiculed. I mean, how many jokes are there about that? And I think there is also a problem in that women are social creatures, and yet this is something that we do not share and we do not discuss. So we sit here in isolation thinking that we are the only ones suffering from it, and it's embarrassing and it's humiliating, and that self-imposed isolation will then lead us towards anxiety and depression. I mean, women will be and just in general, incontinence, um, the the potential for urine leakage in public will increase your anxiety, and then suddenly you start looking, where is the bathroom at, you have to worry about everywhere you go. Are you going to have access to a bathroom? And then you're going to see people start limiting their activities and such just because they are going to potentially be in an unfamiliar surrounding and situation, and then they're not going to know where the bathroom is. And that creates so much distress within a person. And then from there, the social withdrawal just because they have a fear of leakage. And it then will start impacting the quality of their life as they start uh, retreating from social activities. And then it creates problems within relationships because suddenly you are not going to be able to be that person that you were once before, solely because you are so concerned about the incontinence. And then it is going to impact sexual health, because how can you feel as if you want to participate in sexual activities if you're constantly concerned about leaking urine with your partner? So this will then further create lower self-esteem and low self-image and just decrease your confidence. And it is just going to impact your professional life. I mean, how are you going to hold a job if you need to go to the bathroom every 15 minutes due to a situation within your bladder, whether it's any number of potential diseases? And then, here we are, we know, as I mean, as an occupational therapist, as a pelvic floor therapist, we are taught how sex is an ADL, an activity of daily living. So you're not able to participate in that. You are having trouble with your toileting because you need to be able to get to the bathroom. You suddenly have to change how you're dressing because you need to have that easy access in order to get to the bathroom in time. People are going, just like Dr. Cohn said about limiting your fluid intake, people are going to be watching what they're eating and drinking. And then it's just going to impact the person as a whole and just create so much distress. And it's sort of just like he was saying, that situation, what's coming first, the incontinence or the anxiety, depression, we don't, it all sort of just blends together and becomes a huge problem for a person. And we keep hearing that this is normal. People will say that it's normal, but it's not. It's a common thing, but people don't discuss it and they're not told about it. So therefore it just becomes isolating. And everything that I just said, you're just going to suffer as a person.
Thank you so much for sharing generously. You're really helping to shape the true physiologic and psychological impact. Let's build on what you shared. Can you give some insights into the social stigma associated with urinary incontinence and how it affects the seeking of treatments by women who experience urinary incontinence?
Yeah, so there are a lot of delays in seeking of help for it. Um, you know, Usually a lot of times somebody is not going to actually mention it to their provider until it is possibly a huge problem. And as was said, they're getting the UTIs and everything else, but there were steps along the way that could have been taken in order to prevent it from having gotten to the extreme case that it had become. Just the idea of discussing it when people feel so lonely and isolated, it's very hard to address. And their conversations are just not being had, whether it's from the medical side or the patient side, or just as people in general. We're not addressing the fact that this is unfortunately a common um, situation that can occur to someone based on a myriad of reasons. And therefore, they're not asking for help. They are potentially not even reporting. I mean, Dr. Cohn said that it largely or more so is affecting Caucasian women. However, what if the other women, whether they're Black, Hispanic, Asian, anything along those lines, what if they are just not reporting it? Um, and not just that, there could be a cultural or a religious divide that does not allow a person to discuss it. Um, they may not be fully disclosing the extent of their incontinence solely because they are so ashamed and embarrassed about what is happening to their body. And since they don't know that other people are experiencing the same problems and symptoms, they're going to think that they're alone. So they're not going to do it because of that that negative social stigma. And then, they may be trying to manage it on their own. And that is wonderful, but there could have been steps along the way that as professionals we can introduce them to. There are some amazing devices that are coming out that we can utilize in order to help patients, help women um, work towards decreasing the incontinence and possibly even preventing it if we can take the steps early on. So, and the other thing too is uh, when somebody is self-managing and they are self-paying for their products, such as the adult diapers, which I truly hate that term diaper, but that's besides the point. But using those incontinence briefs or the pads, and all of these things just begin to create such an expense. So then a person may start using them and wearing them well past the wear time or wear date that they should, in the sense that the pad may be completely filled, but they're going to keep using it because it is too expensive to continually use more, and that's when we're seeing more and more problems. So it truly is, it begins with a social stigma, and then it affects the whole person, and it can affect them not just monetarily, not just socially, but just in terms of their own global level and global world.
Julie, thank you so much for sharing. Between the physiologic and the psychosocial, you've both highlighted really important points that show us that understanding urinary incontinence is critical, and we have to look at every aspect of it. Let's move to our next section, where we're going to be looking at patient care strategies, and Julie's going to be focused on the emotional aspects and strategies and treatments, and Dr. Michael Cohn will be focused more on the technology. So Julie, first, what role can a healthcare professional play in addressing the emotional impacts of urinary incontinence on their patients?
Well, there are so many things that these professionals can do. I think that the first step is just to begin with open and honest communication about the fact that this is a problem. You are not alone. Here are things we can do. And even just the simple question of, are you experiencing urinary incontinence? I think that is something that is just not addressed. I mean, I had my first child 11 and a half years ago, and it wasn't the dark ages. It was in New York City at a prestigious hospital, and yet I had no idea about it because nobody had discussed that aspect of postpartum care. And so, these are the questions, the statements, the concerns. Let's preemptively address it and get them to begin these conversations. Holistic care, we don't need to jump to the most aggressive treatment. We can start with a conservative treatment and just seeing and getting the patient buy-in so that they can see what they can do in order to change and help. And maybe an aggressive treatment is needed, but the patient can help their recovery in such along the way if they are able to participate in it. And just the understanding of incontinence can help with the treatment, and therefore we're going to have more compliance with their treatment if they have the buy-in. So with us recognizing their emotional needs and their willingness to participate in their recovery and in their care can then dictate the path that can be taken in terms of how we can help them. Um, and I just think it's important to also know the actual problem as to what is causing the incontinence, because we can put a band-aid on it. We can just give them a medication or we can do a surgery, but that doesn't always uh, alleviate the actual problem within itself. Um, so I also know, and it has been shown, that if we can address this early, and why wait until it is a huge problem for the person, if we can address it early through this communication and just bring their awareness to it, we can reduce healthcare costs, which is always so boggling in my mind. Like, it boggles my mind how we are going to as a society, wait until the problem is so bad that we are paying these huge healthcare bills in order to fix it, but it is something that probably could have been addressed and solved with, I mean, a quarter of the cost needed. So we could just really do so much in that area. And then finally, I think it's really important that we can offer support to caregivers, as we know that it does not just, it affects the person along the spectrum of their lifespan. And since not everybody has had the same awareness of incontinence, now a lot of it may fall on the caregiver because, like, as Dr. Cohn said, as a person ages and it becomes more and more prevalent, um, and also a reason for admittance to nursing homes and such, if we are giving the support to the caregivers and showing them what they can do and how they can help, we really could improve a person's just emotional well-being, their support, their mental health in terms of it. I mean, because we know that everything and all of this will suffer due to just due to incontinence.
Thank you so much for that. Really important. I really like that you added the aspect of support for caregivers in there because, um, again, you've highlighted many different points and leaving them out would have been an oversight. So thank you for including that. Let's move on to strategies in terms of education, Julie. Are there any particular patient education strategies that have been shown to be effective in changing the social perceptions or even reducing stigma associated with urinary incontinence?
So there have definitely been a bunch. Just starting with the education materials, the comprehensive, just trying to make sure that the patient is getting it through a multimodality system so they can feel it, they can hear it, they can see it. They are getting handouts, they are getting videos, they are discussing it, they are able to take a larger role within it as they begin to understand. They're able to take a larger role within their recovery and within their treatment planning if they are able to understand the problem and how they can fix it and then getting their buy-in. So, if we can do all this, I mean, as therapists, I know a bunch of us will just take the patient's phone and help make videos on their phone so they can see what they can do. And, we know that there are steps that are needed to take in order to have a person truly integrate the information. So we can have them, repeat it, practice it, and such in front of us so that we know that they understand. And then having the buy in where they can see it as, they know that they had already learned it. So when they watch the video, they will know that they've already learned it and they can continue along the way. Which is why using these digital platforms, I mean, I know technology has made such wonderful advances. Sometimes I feel like I need a teenager to translate all of the technology and, all of this social media stuff that is going on. But there is so much information on the internet and through social media that we can learn, we can see. And yes, it's important to tease out the ones that we can actually trust versus, Dr. Google kind of thing. Um, However, finding the correct stuff, finding peer support and such, not just through the social media, but finding other people. What if we created groups that people could come together and share their strategies and just begin to find a camaraderie with amongst other people and within themselves so that they can reduce the isolation and, combating these negative stereotypes that arise solely because here they are experiencing incontinence and thinking that how could that happen to me, um, and what if it was included in education, what if it was discussed throughout the person's lifespan, starting from sex ed as a kid, here are things that you can do to make sure that your pelvic floor is strong and it's not always just Kegels. It could be anything. And then, as we go along the way, when you're postpartum, this is what you should do. When you're in pregnancy, this is what you should do. And then middle age, as you lose the hormones, and here are other avenues that you can take in order to uh, just get to that and fix and just preemptively discuss and learn about it. So including it in education would be so beneficial for everybody, because again, why wait until there's a problem? Let's address it beforehand, and maybe we can tease out the situations that could have been handled previously. And then finally, let's just create campaigns about it. You know, all these social and advocacy campaigns. There are so many now. There are groups that work and they fight for all these things and advocate for it. So let's advocate for ending the negative social stigma, ending the unnecessary incontinence. I mean, there's so many avenues that we can take in order to just take a role. And as healthcare providers, I feel like we're in this amazing place where we can uniquely handle it and address it. So hopefully we can start making these huge gains.
Wonderful. Thank you so much for that. Great contributions in terms of the psychological, the educational. We're going to build on that. And Dr. Michael Cohn's going to contribute a little bit here. So, Dr. Cohn, you have a very unique perspective as a multinational CEO. In your experience, has culture affected the acceptance of new technologies and treatments related to urinary incontinence?
When you were saying that, you know, as a Swede working with an Israeli company with an US team, introducing it in different cultures, we can clearly see that there is impact, cultural impact, especially maybe in the States or in the Anglo, which is a very Puritan culture. So it's very hard even to have nurses and patients talk about the area, the genital area. And we met introducing it even to in hospitals where nurses were saying, I don't want to clean down there. I don't want to deal with that. I don't want to try the device, you know, they feel uncomfortable. It seems like they're very, very embarrassed to deal with it. And you know, the genital area is, you know, we need it. It's something, you know, we give birth, but when it comes to taking care of it, it seems to be a threshold here, which is a little specific for I think the US, some of the US market. Maybe it's also with the white Puritan heritage here, which we don't maybe have in the Black or Hispanic. You can discuss these kind of issues, but definitely that's a threshold to implementing, evaluating, getting compliance with the new strategies. And with these strategies, just one thing is that people don't know about it, but there is a resistance to deal with it from a culture perspective. So I think TV, media, having famous people talk about it in the US as, you know, we need to deal with this. This is nothing to be, you know, in Sweden, people have a sauna, they're naked together, not a big deal. My wife is American. We had a baby on the beach and the baby was naked and I got reproached from it, you know, what's your baby? You're naked on the street, on the beach. You know, you have to put something on. That's how bad it is. So with that kind of perspective, I'm not surprised that we have a problem here in the US, and we need to have webinars like this to talk about it.
And that's definitely one of the goals of today. Absolutely.
Yeah.
Thank you. Well, let's build on that a little bit. What are some examples of how new technologies have improved patient outcomes?
Yeah, there definitely been a lot of new technologies coming out here because it is a big problem. When we look at pharmacological treatment, you know, take a pill, it's the easiest one. We have urge, you have alpha receptor agonists that can decrease the contractions. You can, because of menopause, you can use local estrogen hormones to make the mucous membranes less sensitive. You even have botulinus injections, like a neurotoxin that can decrease the urge. You can inject it into the bladder. You have antimuscarinic and other neuromodulator substances. They also have side effects because they affect the brain. They affect other parts of the body because it affects all the neural system. And so those that there has been some, you know, you can take those, they are not permanent. If it works, it works, but you have to be looking out for interactions with other substances that you might take for other conditions you have. So you have to look at the side effects from that. There are also some little more invasive technologies. We had sling operations where you lift the urethra to have it close easier, been very popular the past 20 years. People have been pretty good results from that, but over time we've seen now that they are incontinent again, and there is no way to deal with it. It becomes a really chronic condition. So be aware of the long term. They're usually, the studies I've seen have very good, sometimes short-term data, but ask your doctor about the long-term data too before you would make an invasive procedure. So that's invasive. We've seen some improvement in the diaper, in the pads. They're more absorbent, meaning you don't have to change them that much often. So you lay in them longer time, which we talked about the pH before, might not be very good for the skin. And there's also sustainability issue with pads and adult diapers. They take a huge amount of energy, and you have to throw them out in garbage and discard them. So it has a load on the environment. But and you have also technology like implantable electrodes or wearables, where you use electronic stimulation to control the nerves, and that's sometimes less invasive. You don't change the anatomy and anything, and might be something to try. And the past years, also a number of external devices. We have in the US and the hospitals a lot of suction-based devices that you use, and we developed a non-suction external device that is uniquely suitable for nighttime incontinence. Doesn't use any suction or glue, and that's new in the market, and we are introducing it. We think it is a great option for many nighttime incontinent people, patients, women. And one of our distributors here in Sweden, they innovated also an external silicone-based device for stress incontinence, that you just insert. You can take it out, and it, instead of having an invasive, it just pushes a little on the urethra to position it right, so you don't have that when you cough or something, you have that release of urine that you don't want. So that's not introduced in the US market yet, but it's in the European market, in UK and Sweden. Hopefully we can introduce it also in the US. So here you have development on all levels, and it's needed because of the frequency and the big load on the healthcare system, on the individual, that we need to develop all these technologies, and we need to have evaluate them and have the healthcare system adopt them and look at the actual outcome of how to use it. And you probably need to combine some of them and change over time which one you use, which is suited to you and your condition. So that's a kind of an overview over, pharmacological, electronic stimulation, external devices that actually is available on the market.
Thank you for sharing. That's a nice overview on a broad range of products. Do you have advice for healthcare providers who might be considering an exploration of different technologies for their patients?
Yeah, they should. First of all, you should talk about incontinence with your patients. Anamnesis is the most important thing. I learned that as a doctor, and I use that technology in all my life. Ask questions. What's going on? What's the background? Also, you're going to treat an incontinent patient for high blood pressure with a diuretic. You're going to have a disaster. So you better know beforehand that this is the case. So you have to ask that, and how it affects them, and is there a background here? So I think that's the first, and I think doctors, medical doctors, incontinent, if you can't operate on it, they're not that interested. Surgeons, urologists are actually the ones that are responsible for it. and they like to operate. So if it's not invasive, not so interesting. So pelvic nurses like Julia, or physiotherapists in other countries, or urology nurses, they are probably a better partner. And I think we need to train the nurse population in how to deal with incontinence. So I think that's where you have to adopt. That's who you have to address to adopt new things. And there should be protocols, there should be evaluation, and there should be time. And in the crisis, in the general crisis in the hospital system, this is a huge challenge because nurses are striking, underpaid. There are nurses for hire. There is no routine. How are you going to make a study if you don't have consistency in the healthcare system, people who are in one place and they know what protocols to use and so on. And I think if the healthcare system is not going to deal with that method of improving care and evaluating new devices that I know I mentioned many of them, it's going to cost more. We're going to just have a higher and higher healthcare cost, and higher. We have a baby boomer now. We have, the generation just above my generation. It's gigantic. It's going to just cost a lot of money. So that's my advice. There are methods for this, but if you don't have the underlying organization for it, it's not going to happen.
Wonderful. Thank you for those hints. So that really wraps up the second section of today's webinar, where we've discussed patient care strategies with a focus on education and technology that also incorporates the aspects of emotional care. But let's do the final and third section of today's webinar, where we're just going to do a little short, quick, rapid answer to the same question for both of you. So Michael, first, in your experience, what are some of the most common misconceptions about urinary incontinence among patients and or healthcare professionals? And then Julie will answer that same question.
We spoke about the patients and the unwillingness to talk about it. There's only pads. You just have to put something in your pad. You have to collect the urine with a pad, and that's what's available. And I think that's the misconception, because you want to talk about it. So you look at it, and then you need to find, who do I talk to? And that's another thing I can see. And culturally, it's very where do I find the know-how? So you can talk to your normal family doctor about it. They might know something, maybe not. So here there is like a lack of. I think it's connected to from the patient side of view, is that we don't talk about it. It's not on the table. We don't know where to go, and we only hear about the pads. They are huge companies. They advertise, and they have the Bards and the Essities and all these companies. They're available all over. You can get them. So I will deal with myself, and instead of trying to find out how can I manage this in a different way. So I think that's from the patient side. I think Julie probably has a better insight in this than me. On the other hand, on the healthcare,
No, I was going to say, side, I think you're right that urinary incontinence products are not the only way to manage UI, and I think that's a great takeaway from that. Go ahead, I didn't mean to interrupt.
Yeah. No problem. So on the healthcare side, it's the same thing. We have a catheter. You come into the ER, you need to take a urine sample, and you put a urine catheter. Only 50% of the patients with symptoms of UTI, which is very common in elderly, and they can produce a midstream sample. You put the catheter in. Well, 50% don't have UTI, but you cause a UTI, a cavity, with putting the catheter in, and you just routinely put it in because it's an easy way. There's a stress and an easy way to take a urine sample. Well, you can now with a natural fit device, you can have an external catheter that actually takes the sample or takes it in another way. So that's available, but to get it into the hospital, it's a huge challenge. The same with the pad. In the hospital, you just use the pad. Well, when you come home again, or you come to the nursing home, you have a pelvic sacroiliac wound because you routinely just put the pad in, you give the patient diuretics, they have a lot of urine, and they're wet. And so a majority of the wounds are created in the acute care situation. And when they come home or come to the nursing home, they have a pelvic wound and they have to go back in or have very costly treatment for that wound. So there is no strategy, and you need to change your routines. So you just don't give diuretics, and if you do it, you don't have enough care staff to turn the patient or change the diaper because you're not interested in incontinence in acute hospital. So that's an issue because you have a different goal. So integrating incontinence in the total care when the patient comes into the ER, when it's admitted, we have to get the status. Are they incontinent? What kind of incontinence? Just ask the questions and get it in, and it's part of the total care. So I think I think it's not a misunderstanding. I think it's a lack of understanding, if you could call it like that.
Great points. Great points. Julie, you want to build on that? Any misconceptions about UI and patient and healthcare populations?
First of all, just to reiterate that we are told it is normal. We're always envisioning elderly adults in diapers and such, but it is not normal. It doesn't need to happen. It's common. You're not alone, but it is not normal. The whole thought about it affecting men and women equally, I will tell you in my practice, the younger population that I tend to treat are women, whether it's athletes or postpartum. And then as they get, and sometimes I'll have a few men who possibly had an injury or something along those lines. But as men age with the medications that are frequently given for anything along the lines, and they're experiencing erectile dysfunction as well as incontinence. And like Dr. Cohn said, just based upon the prostate, as men get to that stage where they have either enlarged prostate or prostate cancer, that's when I start noticing an uptick in having men in the practice as well. But it does not just affect elderly people, and that is something that has been very isolating for the younger population, in that there are a lot of athletes that are wondering, why am I leaking as I am doing this? And there could, there's a whole host of reasons as to why this could be happening. And, it's important to explore those reasons and determine the cause of it, as mentioned previously. And, people think it will never be able to improve or never be able to be treated, but that's also not true. There are so many things that can be done. In my practice, if I have patient buy-in and the patient understanding, and let's also call it the big if, that if incontinence is really the only problem and that it is due to a weak pelvic floor muscle, we can truly help improve the patient's quality of life and decrease the incontinence. Within, 3 to 4 weeks, they will start noticing a difference. So that could be super huge in terms of giving the patient buy-in that there are things that can be done. But again, there are many different diseases, diagnoses, problems that can arise. So it's important to know the why and how to treat it. And not everybody can be treated the same way. Some devices may not work with that population or that specific diagnosis. That being said, there are things for everybody to be used. And then, just also, again, the stigma and the fact that we're not addressing it. And I feel like if there's one thing that we can all hammer home, it's address it, talk to the patients, talk to people, talk to your friends, talk to everybody, because there is no reason that you should be suffering alone. There is no reason a patient should be suffering alone. And if we can address this with them early on, then we can truly impact a person's life. And there is no reason that we should wait until it is a gigantic problem and the person is unable to leave the house, because as we know, it creates a whole host of other problems. With the decreased activity, you're going to have less muscle, activity, and then they're going to be more weak, and then suddenly you're going to see all of these other side effects spiraling out of control simply because a person is too afraid to leave their house because they are incontinent. And we could have worked with them to address it, whether it's given them a device or whether it's giving them a way to retrain their pelvic floor or a surgical intervention. There are so many things that can be done that a person does not need to suffer.
Julie, thank you so much. Valuable insights there as we've looked from physiologic to psychosocial, from providers to private healthcare citizens. Lots of great information shared today in this webinar. We're getting close to wrapping up, so I'm going to take just a couple of minutes for thanking our sponsor and then give you each a moment or so for a closing remark. So thank you all for attending today's session entitled The Emotional Dimensions of Urinary Incontinence. We've touched on many broad topics that are all building back to that point. We want to thank TillaCare, the sponsor of today's event, the maker of the UriCap Female, the only natural fit external female catheter. Julie, would you like to make some closing remarks today? And then Michael, also for you, and then we'll wrap up.
Yeah, so actually I'm going to make this very personal and share my story and why I think this is a huge issue and why we can address it. But I recently had laparoscopic surgery to remove endometriosis, and I went into the hospital and was put under the anesthesia and such, and a catheter was inserted while, during the surgery. So I came out of the surgery and I should be recovering from the surgery itself because it was painful. They found the spots, they had to excise them. It was not necessarily fun, but the worst part about it was I wound up with UTI because of the catheter. And that is something that could have been completely avoided, and I would have been able to focus on my recovery from the laparoscopic surgery instead of suddenly having to deal with a painful UTI if a device such as the UriCap Female would have been available and would have been used in the surgery. So I am so passionate about the fact that I truly believe that this device needs to be in more medical facilities and within hospitals and such, because just imagine, here they are, they're treating me for that, and they could have avoided those costs if they would have spent the money to just get that little device. So an external catheter would have been a much better, less invasive way to go. So that is my soapbox that I will get off of. However, I truly believe that it is something that would have changed my life and my recovery and made everything better for me if there would have been something like that in the operating room.
Thank you for sharing your story, Julie. And you're also, UriCap's also available via Pelvic Tech, your company, correct?
Yes, it is. Yes, it is.
Wonderful.
And
thank you.
Like the other places, we can work with helping to figure out how to use it best. So there's so many different ways to learn about it, but I'm extremely passionate about it, as you can tell. So
thank you. It's clear. Thank you. Dr. Michael Cohn, thank you today. Would you have any closing remarks for us?
Sure. Thank you, Christy, first for organizing this webinar together, and Julie for sharing so much. And we are very happy at TillaCare to be able to introduce the unique UriCap Female into the US market now. As Chris said, it's a natural fit, very external, soft and comfortable urine collection device. We spent 5 years developing this device. It does not need suction or glue, so it's very unique. And it's uniquely suited, I would say, to Julie, to be used for your patient at nighttime use. Don't have to fall, don't have to get up. And also to collect urine in a case where you need to take a urine sample, or you want to collect urine during an operation where you're leaking. You might be doing it just to collect the urine sample. And it's just into a bag, and the best thing, nighttime use. The patient doesn't have to wake up, or the caretaker doesn't have to wake up. You can sleep through the night. And what does that to your well-being? We all know that. And we're so happy it's also covered by Medicare Part B. And anyone who's interested, you're welcome to visit our homepage or contact Julie. And she's also on our homepage, www.tillacare.com. And you're welcome to learn more of what we have to offer. And thank you for attending. I really appreciate it. Oh, you're on mute.
Thank you so much. Thank you, Michael. Thank you, Julie, both for joining us today. And then the final bit is the disclaimer. Today's information is to be considered educational and informational, and nothing discussed today can replace the advice of your professional and your own personal physician or healthcare provider. So we thank you again. Thank TillaCare for sponsoring today's event. Thank you, Dr. Michael Cohn, for joining us from Copenhagen, and Julie Blacker from joining us from Tampa, Florida. Have a great day, everyone. And if any questions, reach out to us individually on LinkedIn. Have a great day. Bye-bye.